a lot of code. Let's take the number ideas.
All right, well, let's go ahead and start. Ryan is actually in Michigan. I was with him yesterday at the University of Wisconsin. We had a visit with the Wisconsin CTSA, and so he decided to visit some family, so we're delighted that he's taking a day off. Before I start, I'd like to wait for a couple others maybe to join us. I'd like to go around the room and hear from each of you about the research you're doing. Tell me, I'm not interested specifically in the projects you're working on, but I'd like to know how do you characterize the type of work you're doing? What sort of adjectives would you use to describe it in the constructs of health services research, comparative effectiveness research, outcomes research? What do you sort of see the broad discipline you're working in? And tell me also a little bit, just as we go around, about what types of grants you've written, what agencies you're interested either in writing to or ones that you've written to already. So we'll start here.
So, Justin Thomas, for those of you who I haven't met. If I had to pick one adjective, it would be translational, because my research project has a basic science component, a clinical component, and a population component, broadly focused on sleep and hypertension. So I would say...
What type of, would you say it's early phase, later phase translational? Where would you put it in the translational spectrum?
Well, so for the basic science that I'm dabbling in would be early phase.
Okay.
The clinical is, essentially we're looking at the effect of salt diet on sleep apnea and hypertension. So it's more patient-centered comparative effectiveness in terms of salt diet.
Good. And what funding agencies have you thought about?
So this fall I'll be submitting to HLPI.
Excellent.
And then there's also AHA and the institutional.
Good.
I'm Stephanie Tyson. I'm actually pretty early in my career and first year doctoral about that.
Yeah.
So I'm interested in comparative effectiveness and patient-centered outcomes and probably more later translational research. So.
Great. Thank you.
I'm Bob Haas, and we do research in surgical quality and surgical value. And we work under the VA. So
what about funding? So VA?
Yeah.
Okay.
And
do you view that as strictly quality improvement research, or do you also see it as sort of evidence implementation science?
I think those two go hand in hand.
Okay. Good. Talk about that.
I'm John Donnelly. I'm a third-year PhD student in epidemiology, and most of my work is focused on kind of sepsis health services or sepsis outcome research. I think it's like outcomes research. It's the broad umbrella. In terms of agencies, we recently put in my F31 to NIGMS.
Mm-hmm.
No. What were you saying? I kind of got in late.
Just the type of research you do, not specifically the project by title, but what is sort of the domain in terms of outcomes, effectiveness, comparative effectiveness, patient-centered outcomes? How would you describe it? What adjectives would you use? And then what funding agencies have you been considering?
So I'm doing Core research in CFPD in particular, interested in K-12 or K-23 funding sources. I'm second for pulmonary drug.
My name is Maylage, and my research is more on kind of quality of life in kids with chronic illnesses, so how they quantify the effect of the disease. And I have applied to an PhD with an F31.
So quality of life, is it more descriptive? Are you working with cohorts?
Mm-hmm. Yeah, descriptive.
What are the methods that you're using?
So we're collecting a clinical population from children. Right now it's cross-sectional. We're not following them over time.
Okay.
But yeah, it's all questionnaire. Yeah, questionnaire children and parents.
Observational, interventional?
Right now it's observational.
Great.
Parent and child report.
Terrific.
I'm Whitney Smith. I'm a doctoral candidate in healthcare organization and policy, and the work that I've been doing lately, I guess, fits more into the health services and outcomes research box, and that we're looking at how, at psychological barriers to HIV medication adherence, and I am looking to submit a grant to NIMH, so National Institute of Mental Health.
Terrific.
I'm Haley Kendrick. I'm a predoctoral fellow in medical sociology program, and generally I'm interested in health disparities and inequality and looking at social and structural level causes that influence different outcomes for different people. So a lot of population level stuff, and now looking into adherence and quality of life type outcomes for people living with HIV. I haven't thought or looked into much of funding sources at this point.
Soon. Okay, good. We were just talking a little bit about the sort of description of the type of research we do or we're interested in, and if you thought yet about any funding agencies that you might pursue.
Yeah, my name is Shai Adela. I'm a fourth year MD PhD student in my second year of graduate school. I finally submitted my F30A.
Congratulations.
Thank you, to the NIDDK. My dissertation is, it's a randomized controlled trial that tries to assess the effects of a low carbohydrate and low fat diet and obesity-related outcomes, and then quality of life and eating behaviors.
Great, great. And I think we have some slightly more senior people, not by age, but just in terms of where they are in their career necessarily. We'll go around the back here. We can start.
Sure, I'm Tony Parks. I'm a pediatrician. My research in the past was on health services, quality outcomes research. I'm particularly interested in applicability of personalized health in the information infrastructure institutions right now. And I'm not really working on grants, but I am on the HRQ, HSQR study section, so I review grants right now.
Thanks for joining us, Tony.
Pleasure.
I do work that relates to chronic pain in patients with HIV. I've done clinical epidemiology work in the past, and now focusing more on behavioral science and developing a behavioral intervention, testing a behavioral intervention. So my work is clinical research and more on the later stage of the translational. And
Thanks for being here, Jessica.
Hi, I'm Monica Swami. I'm a fourth year doctoral student in healthcare organization policy. And I'm interested in healthcare quality and patient safety outcomes research.
And you've written a few grants. You've gotten funded from?
Yes, sir. NIA, National Institute.
NIA. Great, great. Yeah, and then we'll
I'm Pat Patrician, and I'm a professor in the School of Nursing, and my area of research is health services research in nursing. Primarily, I look at organization of nursing services on inpatient units and patient safety outcomes associated with that. And I've been funded by Department of Defense mostly. I have 2 grants cooking right now.
Department of Defense on this slide.
And one of them is NIOSH. So we're looking at circadian dysfunctions in night shift nurses.
Great. Lang, thanks for joining.
I'm not Chen, I'm a statistician, work with Saag and Steroid, mainly on the claim data, Medicare, Medicaid, and some of the insurance claim as well.
Fantastic. Well, that was really interesting. A very eclectic group of projects and interests. And as you each described what you were doing, very few of you used exactly the same adjectives to talk about what I think collectively probably fits into the spectrum of outcomes and effectiveness research. It really highlights both some terminology challenges and the interdisciplinary and very multidisciplinary nature of the work we do. So I want to provide an overview, and please interrupt me at any time as we go. This is really mostly a springboard for discussion. I've got a few objectives. One is just to sort of, again, focus a little bit on some of the terminology, and then to give some examples of the types of research that fit into some of these different categories. Just really, again, to illustrate what people do and how we think about the broad field of outcomes and effectiveness research. Now, as a rheumatologist, I'll be highlighting osteoporosis and arthritis studies, but it's, again, just strictly examples. And we'll talk a little bit about pharmacoepi, which Lang just described his interest in. I know if anybody in the room mentioned pragmatic trials, which is something that has been a growing focus. We'll discuss that briefly. And then I did hear some discussion about healthcare quality, talk about measurement, and then the idea of implementation science. What is that? So several of you did speak to the spectrum of translational research, and this is a older slide that shows what Institute of Medicine considers to be different phases of research. When we normally think about translational research, we're looking to the left. We're thinking about from bench to bedside. But most of what all of you are doing, I think, Justin, maybe you said your work early on has been a little more T1, but most of you are focused in the later phase, T2 to T4 areas. And we normally think about CER and PCOR, several of you use those terms, as later stage work, and it builds on the foundations of epidemiology. Health services research is a slightly older term. It's been around perhaps the longest, and those of us who have been affiliated with Academy Health and been involved with that, and in fact a training grant from ARC that several of you are funded on, the T32, is the health services training grant. So that's another term that we see. And all of this ultimately has implications for public health and for policy. And this is the way that I see it, and you could add several other circles to this. It would just make the slide busier, but it would basically say the same thing, that these are widely overlapping topics that we think about. Health services research mostly is synonymous. Pharmacoepi sort of sits a little bit to the side because it is a very specific area where we mostly work with large databases. And then CER and PCOR are way more similar than they are different. And some of it is a vestige of politics. You know, CER came out at a time when the stimulus went into effect. There was about $1 billion or so that was invested with the funding stimulus, that all this money went to NIH and some to ARC. And then there was some political baggage, you know, talk about death panels and other things that kind of derailed the discussion of CER. So then along came PCORI. PCORI was a new government entity that had been supported by the Affordable Health Care Act, and PCOR, Patient-Centered Outcomes Research, was kind of a twist on CER, gave it a slightly new name, but also emphasized the importance of engaging patients, not just as subjects or as consultants or members of focus groups, but actually as investigators in the projects. And so this has been one of the real big developments, and what's interesting is you all talked about where you have thought about funding and looked for funding. Nobody mentioned PCORI. And so I think as an institution, we need to really get this on our radar, at least while it's there. We're not sure what's going to happen with, some of it will depend on the election, I presume, in terms of whether this entity exists, but PCORI, the Patient-Centered Outcomes Research Institute, has about $500 million to invest in research very similar to all the projects that you described. And the way it works is every time somebody buys insurance, either public or private insurance, $1 goes into a trust fund that is set aside for supporting this. And within it, there are a number of standing funding announcements that really cover the spectrum of the kinds of research that we're all interested in: assessment, prevention, improving healthcare systems, communication, disparities was mentioned, and the methodological research. Lang and others with our peer group have been very involved in thinking about methodologies. There's also been a number of set-aside funding announcements, including one in Pragmatic Clinical Trials. And then the other thing PCORI has done is they've established a series of networks. And collectively, this is known as PCORNet. Within PCORNet, there are clinical data research networks, CDRNs, and there are patient-powered research networks, PPRNs. UAB is part of a PPRN. Jeff Curtis leads a subcontract to a PPRN, which is led by a social media group called Creaky Joints. They're a place where people with arthritis go to vet their issues online. It's basically a chat room. And now that chat room has been converted into a research hub for understanding that. And the goal with all of this is to think about how do we link things together. And so PCORNet has been working on common data models using things like I2B2 and OMAP and other some of these other very standard approaches now that have become a way to take data beyond just claims data and start to aggregate it nationally. So PCOR net and the CTSA mechanism, we're in the CTSA hub here, are working together finally, which is good news, to think about data sharing across the academic and community-based centers that collect data in clinical care, and thinking about how do we harness that to do research. And interestingly, the CDRN idea is mostly focused so far on building infrastructure, but they also finally funded, for the first time, a pragmatic trial where they're using this structure. And I saw an email just in the last couple of days that they just enrolled the first patient into that pragmatic trial, which is looking at different doses of aspirin as a preventive therapy after cardiovascular disease. And so this is a direct-to-patient study, and we'll talk a little bit about the construct of large, simple, and pragmatic trials in just a minute. Here's what they're funding, just in terms of the disease content, and probably not any real surprises here. These are diseases that have high public health relevance, by and large. One of the things they emphasize, and as part of their administrative charge, is to also focus on rare diseases. So there are some specific announcements that highlight the importance of also thinking about rare conditions, not just common things.
Ken, in the slide before this, that one,
yep.
What are in the none and other categories? Is it mostly the methods research?
I don't know. I have to look that up, but that would make sense, I guess, wouldn't it, to have probably things that are cross-cutting, you know, where you can't really say it's just about a specific disease. I would guess that would be, yeah, they do, based on that final RFA, as part of their standing announcements. I'm guessing that would be in there. I'll find that out before I give this again, but I don't know. And this is not the most updated. This is only the first two cycles. So there's much more recent data. We're actually involved this week and next. Next week's the deadline in responding to a PCOR RFA where the focus is on dissemination. So the goal is, you know, normally as investigators, we have some responsibility for disseminating what we do, but most of our dissemination, frankly, is, you know, you go to a meeting, you give a talk, you write a paper, it shows up in a peer-reviewed journal. And what PCOR is interested in is wider dissemination, and so they've actually commissioned a center, or centers, depending on how much money they have, to systematically review the projects that they're working on, decide which ones have the highest impact, and then to disseminate those nationally. So this is another sort of, PCOR is an odd beast, really. I think for those who's written a grant or been involved in a PCOR grant, so just a couple of us, it's kind of weird, okay? I mean, it's got a very different peer review mechanism. The patients are reviewers, and some of the most damaging comments on the critiques are, you know, you didn't involve patients enough. How come the patients weren't involved in picking these questions and designing this instrument? So you've got to engage the patients from the get-go to be successful with PCOR. That's really critical to your success with them. And there's all sorts of different rules. You have to follow a methodological rubric where you need to cite sort of chapter verse in your grant of the actual part of the methods report that you're following as you outline the sections of the grant. For those used to writing NIH grants, it's different. You should talk to one of us who's been involved in writing one of these, and there's probably a dozen or more people now at UAB that have had experience, both positive and mostly, unfortunately, negative, as is true with all grant writing, in submitting to PCOR. But we've learned some things as we've gone. Oh, and so this one just shows that it's not about RCTs, although they're moving more towards the idea of PCTs, but it's also about bringing in qualitative work. As you might expect when we're talking about patient-centered outcomes research, we want to get the patient perspective in there, and that's where qualitative research fits in, and mixed methods research is important. Here's one example, just to bring this further home, of a CER project that was funded by PCOR, looking at improving care for stroke survivors, and it involved a rehab approach, comparing different strategies. Now, when you do comparative effectiveness research, effectiveness is the key word. It's not comparative efficacy research. Come back to that in a minute. but you've got to find things that work. So you can't test things and explain whether they work or not. You take things that work and you compare one against the other. And here's the linkage to Medicare data, very popular to pull in administrative claims data, large databases, increases generalizability. So a pretty nice example. Nowadays, something like this might have been suitable for the Pragmatic Trials RFA that Cohort has. That's $10 million for that. That's a much larger scale activity, and they're more interested now in bigger grants beyond some of these smaller ones that they've been funding. So when we wrote our K-12, and we have some K-12 people in the room here, we wrote our K-12 in patient-centered outcomes research. And one of the interesting things about Cohort is when it comes time to do training, when they have to do training, that money goes to AHRQ. So 20% of the Cohort budget is shifted to AHRQ, the Agency for Healthcare Research and Quality, and they run all the training. So we wrote to AHRQ for a Cohort K-12, and this is what was in the RFA. And that's why I wanted to hear as we went around the room at the beginning what adjectives you use, because these are the adjectives that the RFA uses in defining what is outcomes, effectiveness, patient-centered outcomes research. So longitudinal cohorts, real-world clinical trials, evidence implementation, risk communication, dissemination, pharmacoeconomics, and healthcare. Now, I have to put a little asterisk there because along with all the politics that I've started to discuss, one of the political nuances of the core is you can't talk about cost. You can talk about comparative effectiveness, but cost is a dirty word. And again, this has to do with not, the Congress and the people involved with developing this begrudgingly said, okay, you can have this agency, but we don't want to know whether one drug is more cost effective than another. And we know also that it's challenging. I mean, it's tough enough to do comparative effectiveness research. Then when you throw in cost, you start to often have a lot of assumptions if you're doing modeling or even if you're trying to measure it directly that make it somewhat difficult. But ultimately, that's really the question that I think a lot of us would like to know. Methodologic innovations, and then something that nobody mentioned and that we at UAB are involved in, but perhaps not as much as some of us would like, the idea of systematic reviews. And we have actually, some may know, an arm of the Cochrane collaboration. Jazz Singh is a regional site for the Cochrane collaboration, which is the sort of the home of systematic review or meta-analyses. Now, I borrowed this slide a number of years ago from a colleague, an epidemiologist in rheumatology, Claire Bombardier in Montreal. And I like this slide a lot because it really reminds us of where what we do fits into sort of the overall rubric of research. On the right is generating evidence, and on the left is implementing evidence. And most of us are in the first box, right? We do studies where we're trying to understand associations in disease. We're trying to either in an observational way or in an interventional way generate evidence. Once we generate it, sometimes we may want to aggregate it across studies, and there is a science around doing meta-analyses. And then once you have sort of synthesized the evidence, it's time to define what does it say? And so you can do that in the form of a guideline. You might have an economic analyses. There's a lot of debate in the guideline communities around whether costs go into guidelines or not. We've been involved in developing these from the American College of Rheumatology, and this is a perpetual debate. Normally we don't include economic considerations, but sometimes they're important. And then once you've had a guideline developed, the guideline is the best standard. What is the thing that you ultimately should do? The next question is, what is the least amount that you should do? And that really is how to think about a quality indicator, a performance measure quality indicator, largely synonymous, some subtle nuances around the differences. And so we can develop those. We can often go from a guideline to a quality measure, often using a process, a formal group process. A grade is the method that people use for guidelines and different ways, including RAND UCLA and other methods to develop quality indicators. And then the traditional focus of health services research has been around practice pattern variation. The pivotal original work of Wenberg at Dartmouth. And Wenberg established that there was large variation in the rates of hysterectomy across the country. And this was very influential in saying, now wait a second, if we're getting this done twice as much in this region as in this region, maybe there's a quality issue. And so then ultimately, the final step is how do we translate the research into practice? And that can be done using evidence implementation methods. So let me give a few examples. And I want to start with cohorts and sort of pharmacoepi. And I think it's good for all of us to just go back to sort of the fundamentals and think about general principles of study design, epi study design. And we have descriptive studies and analytic studies. Among analytic studies, they can be prospective, and if they're prospective, they can be observational or they can be interventional. And then they can be a retrospective cohort, or they could be a case control study. Or we could do cross-sectional studies, and there we worry about the ecologic fallacy. If you see something at a population level, does that really pertain to what's going on, and is there really a even potential for a causal association? To drill down a bit further, looking at the most common observational study designs, case control, prospective, and retrospective cohort, it depends where you are as an investigator. Are you at the beginning of the study? If you're doing a prospective cohort, two great examples at UAB are Regards and Cardia, two of our premier cohorts, where we started at the beginning. We started collecting information on risk factors and other interesting things that we think may be associated with an eventual outcome, and then we follow people forward. Or we could do a retrospective cohort. I'll give an example of that. Case control studies, very commonly done, perhaps slightly more subject to some of the biases around selecting appropriate control groups. And again, as a review for nearly all of you, how do we assess risk? How do we talk about it? In cohorts, we talk about relative risk for rare diseases. A relative risk approaches an odds ratio. In case control studies, using logistic regression, we generate odds ratios, the odds of having the disease, if you're exposed or not exposed, the relative risk being the incidence in the exposed over the incidence in the unexposed. And that gives us a sense of relative risk, but what we often care more about from a public health perspective is absolute risk, the risk difference, and that is defined here as well. So here's just an example from a large, very famous cohort, the Women's Health Initiative, where you can see the different relative risks for different outcomes of receiving estrogen in combination with progestin. In some cases, the risk is deleterious. There's an increased risk of a bad outcome. In the case of hip fractures, we see a 34% risk reduction. And you can also look then at the excess or reduced risk, the absolute risk. You can see that in some cases you have fewer events, and in other cases, per 10,000, you have an increased number of events. So when you see an association in epidemiology, what are the possibilities? So what is it? What are the different things that could be going on if you find relative risks like this? What is it? How do you interpret it? So one possibility is it's true. It's true. Okay. So it could be true, right? There might actually be an association. What else? Okay, so it could be chance, right? And that's why we use statistics. Lang is here to keep us straight on that. And so we could look at the p-value, and we could account for multiple comparisons and other things and try to determine whether there's a type 1 error. What are the two other possibilities?
It's due to something else.
Due to something else, like what?
A confounder.
A confounder. So it could be due to confounding. And lastly,
There's no association.
no association. Yes, I think that's the last one. I guess there's two more. Okay. Well, that would be chance, really, wouldn't it? So no association. So one more is bias. Okay. So what's in between bias and confounding? Again, review for the epi people in the room, but good for all of us. Bias is a systematic error. We can't fix bias with analysis. We have to fix bias in design. Confounding, the classic example is it looks like alcohol causes lung cancer. Drinking alcohol causes lung cancer. The people that drink alcohol have a slightly greater risk of being smokers. So that's the confounder in that association. And there's all sorts of ways we can handle this. We can handle this at a design phase, or we can handle this at an analytic phase. What are the design strategies? Well, the best is to randomize. If you randomize in an RCT, you ought to have balance in those confounding factors between the two groups if the study's large enough. Or you could restrict, or you might do matching. Matching has got problems because things you match on you can't analyze for. More commonly, though, we think about it in the analysis phase. We think about using multivariable analyses, stratified analyses, newer approaches, propensity scores, instrumental variables, structural equations, other approaches that allow us to address confounding to some degree, or sensitivity analyses, looking at the best case and worst case and what impact that might have on the conclusions. One final just general principle is the risk factor. And when I get a paper to read from somebody, I generally cross out risk factor and change it to factor or variable, because it's pejorative to say it's a risk factor, right? I mean, it implies causality to some degree. So we don't tend to like the term too much because it doesn't mean it's the cause. It just often can be the analogy of looking for the key under the lamppost. That just happens to be what we found because that's what we looked for. So it ought to be hypothesis generating for the most part, occasionally leading us to the idea of cause and effect. So Bradford Hill did a great job of helping us think about in epidemiology what is causality and what are the things that help establish in an observational study that something is more likely to be causal. And again, I just read just in the last week some specific aims for a grant from one of our UAB faculty members, and it said, we're going to establish causality between X and Y. I said, no, you're going to get killed by the reviewers. You can never say that on the basis of a single observational study. But what we can do is we can look at things that increase the likelihood that there's causality, the strength of the association, the dose response, consistency, temporality, biological plausibility, and that's what most of us are trained in. You know, what is there a biological rationale, and what do the lab experiments show? And then, in some cases, although most of the time not possible, is it reversible? So that's good in an infectious sequelae, for example. So let me give a couple examples now. So this was a study I did a few years back, a retrospective cohort study, type of observational design to assess the association of steroids with bad outcomes. So we identified rheumatoid arthritis patients who were users of glucocorticoids by looking through their medical records. We found a similar sized group of non-steroid users who were matched by age, sex, and duration of disease. And then we looked at a list of things that are common bad outcomes of taking glucocorticoids. And this is a list for clinicians that is quite familiar. You can see that fractures, bad outcomes in the bone, were at the very top of the list. And then we showed a dose-response relationship to further suggest that there might be a true relationship. And you can see that if you didn't take steroids, you still had a chance of getting a bad outcome because people with rheumatoid arthritis are sicker. But if you took 10 to 15 milligrams of prednisone, that went from 20 to 80% at 5 years in terms of the likelihood of getting that bad outcome. And when we looked at a multivariable logistic regression analysis, we found, again, a dose-response relationship with the steroid association, which was explained in part by disease severity. People with bad rheumatoid arthritis, denoted by having nodules on their skin and having damage to their bones, were also more likely. So we analytically accounted as best as we could for disease severity, and we still found this relationship. Well, that was interesting, but what are the limitations of this type of a study? First, that the people that get treated with steroids are not treated by chance. They're treated for very specific reasons. They tend to be sicker. The doctors and the patients identify and treat them more aggressively. So this is the problem when you do observational studies of drugs, devices, and biologics. It's confounding by indication. It's a type of selection bias, susceptibility bias, but it's going to by itself lead to a bad outcome. The other problem in such a cohort is a detection bias. And if we're looking at people that aren't followed in a systematic way in a clinical study, but just in clinical care, those that the doctors are more concerned about are going to be seen more often, and they're more likely to have an event detected. So can we use RCTs to fix these questions? So in the case of steroids, we'd like to, and we know that RCTs are right at the top of the pyramid of evidence. We want to go as high in this pyramid as we can. Down at the bottom is unsystematic clinical observations, physiologic studies, single reports, case reports, and then we move into some of the more observational study designs. But randomized trials are towards the top of the list. Here's the problem, though. Most of the studies of steroids in rheumatoid arthritis are just of a few hundred people. And we're only going to be able to pick up an adverse outcome if it's fairly rare, first of all, and or if it's fairly common rather, with 20% incidence, and we're looking for a twofold increased risk. On the other hand, if we're looking for something that's even as rare as a 50% increase, which is not all that much, we need thousands of people. So clinical trials generally are inadequate to detect adverse effects. We really do rely, for the most part, on observational studies. And needless to say, the FDA takes a lot of heat, but and we've got our esteemed lay publications telling us what we need to do. We need to use the claims data, right? We collect all this billing data. Wouldn't that be great? We could just study that and we'd have all the answers. So what is claims data? So claims data is taking all of the healthcare information from people as it's collected for billing purposes. This should say ICD-10 now, and compiling all that. And of course at UAB we have an embarrassment of riches because we have a lot of expertise in this area thanks to Lang and others. We have the peer group, which some of you have interfaced with. We have Medicare, Medicaid. We used Aetna data. We used Kaiser data. We used IMS data. The VA is a great source of data, electronic data, in addition to claims data. You've got EHR data that's been collected in a very standardized way. So we've got a lot of data here that allows us to look at healthcare outcomes in a systematic way. Let me give an example of how we can use this data. And this is some work in rheumatoid arthritis by one of our pediatric rheumatologists, Tim Buchelman, who was a former case scholar on the CTSA grant. And we've got this group of medicines now that you probably, even if you're not in the field, have heard about, because if you turn on TV at the time of the 10 o'clock news, you'll see commercials for these drugs. Now think about it. These drugs, rheumatoid arthritis affects 1 to 2% of the population. We've got psoriasis and psoriatic arthritis, which maybe picks up another 4 or 5%. At most, 10% of the population has a disease for which one of these drugs could be used, yet they're able to advertise on the primetime TV. They're making a fortune on these medicines, okay? Part of the reason is because they work so well. They're very efficacious. However, there are some concerns, and there's questions about adverse effects, those that are shown on this slide, and black box warnings that exist for these drugs. The question, though, is it confounding by indication? Is it that the people who are selected to receive these stronger anti-inflammatory medicines, these so-called anti-TNF drugs, have worse disease? Or could it be that they're also more likely to be on other medicines like glucocorticoids that also lead to bad outcomes? So here was one of the warnings that was present, and Tim was interested in this as it related to children, so he decided to look at Medicaid data and to compare malignancy rates among different treatment for juvenile inflammatory arthritis, which is actually a very separate disease than rheumatoid arthritis, but has some similarities, and to understand that within kids. And here's what he found in his paper, is that for having juvenile inflammatory arthritis, regrettably, you're at some risk for having malignancy, because this disease stimulates the immune system and may lead to particularly hematologic malignancy. And it really didn't matter too much whether you took methotrexate or had just juvenile arthritis overall, but if you took one of these new drugs, there weren't any cases. Now, one of the problems here is the possibility of a type 2 error. Might he have missed an effect because he didn't have enough information, the sample size was too small, so he's now back looking at a newer cohort to identify this further. So we've done a lot of work with claims data, and it's led to some important publications. These are just some examples of some JAMA papers, a pretty high-impact journal, that shows that if you do it well, if you take this data, you use it properly, you recognize the limitations, and you work collaboratively, in this case, through a multi-site collaboration, which involved both Medicare and private sector data, you are able to produce important outcomes that can have some public health impact and influence our thinking about these associations. So what can administrative data do well? It's got good generalizability, And in particular, it can complement other approaches. The best scenario is to have administrative data linked to EHR data or linked to registry data, where you can have some of the granularity that you need of clinical care, but also some of the generalizability and the ease of assessing outcomes long term. What can't it do well when it's used alone? Well, it can't accurately classify. There's rule-outs, there's miscoding, there's all sorts of challenges in using this data, so we have to keep that in mind. We also don't know about disease activity and severity. In the case of rheumatoid arthritis, we don't know how many joints are swollen, we don't know a lot of the things about quality of life that we'd like to know in this regard. And it's difficult to differentiate incidence and prevalence. Comorbidities are another challenge in using this type of data. Now, others have suggested that this may not be such a good idea. Saag says, if you find a study that was not randomized, we suggest you stop reading it and go to the next article. Okay, Feinstein's a little more sanguine. We need both observational studies and RCTs. They answer different questions. And here's John Ioannidis, a bit of a heretic, who shows us that large RCTs have a pretty high likelihood of finding the truth. Meta-analyses do a little bit better if the trials are small, but well-done epi studies, only 20% likely to find the right result. And the classic example that's been used is the finding that observational studies of hormones for women yielded the wrong result. And when WHI came along, the Women's Health Initiative, we actually got the right result. Well, it turns out that when people went back and used very sophisticated methods to address this confounding by indication, they used marginal structural models to address this, they got the same result. So it probably was the quality of the study. So there's been arguments that well-designed observational studies do not systematically overestimate the magnitude. There's little evidence that observational studies were consistently larger or qualitatively different. And this is my conclusion. That it's not fair to compare good RCTs with bad observational studies. We need better observational studies, and we need to have them done in a more rigorous way using inclusion-exclusion criteria, case report forms, and validated endpoints. All right, so that's the first topic. Next, I want to mention what are real-world trials, and many have seen this. This is the phases of clinical drug development, phase 1, phase 2, phase 3. Most of the studies we do here at UAB are phase 2 or phase 3. Phase 3 is the pivotal study for drug approval. And then a lot of what we've been talking about is phase 4. So after a drug has been approved, understanding its safety and its real-world effectiveness. So that would be considered a phase 4 study. Well, there are problems here, and historically most of our studies, our traditional drug studies, compare things to placebo. And that is important in explaining whether it works, but it doesn't answer the question of how well does it work compared to existing therapies. So we can't answer all of our questions by traditional clinical trials, and traditionally they've been very expensive and inefficient. So the idea of a pragmatic trial is not a new one, but it's gained some traction recently with PCORI. And if we think about a traditional randomized controlled trial, an RCT, and compare it with a pragmatic clinical trial, an RCT has great internal validity. It answers a very specific question very well. A pragmatic trial often has less robust internal validity and better external validity. Generalizability, same thing. Minimal eligibility criteria, low risk, simple treatments, objective outcomes. Those are some of the features. So I started to talk about this earlier, efficacy versus effectiveness. Efficacy is what happens in selected populations. We have problems with healthy person effect, the absence of subgroups, it's tightly controlled, it has very strict protocols, and we generally want people to have very good adherence to answer the important question. So what is an explanatory study? It's to determine whether a new treatment possesses the favorable activity in man, which laboratory studies have led us to suspect. Can it work under ideal circumstances? This is an efficacy trial. A pragmatic trial is to assess the practical value in relationship to other existing treatments. Does it work under the usual circumstances? And these are often termed effectiveness trials, management trials, are somewhat synonymously large, simple trials. Now, not all large, simple trials are pragmatic, and not all pragmatic trials are necessarily large trials, but they're fairly close. Here's an example. If we think about this, it's not a dichotomy, but it's a continuum. And if we think just about one particular component, patient compliance, so the most strict approach would be a placebo run-in. We do an RCT. We want to make sure people are going to adhere to the protocol. So we assess them for some period of time on placebo to see how they do and to make sure they're following the instructions properly. And then we do that before the study starts. We could apply a compliance improving strategy to all of them. That would be slightly less explanatory. We can monitor compliance and intervene if it was low. We could monitor it only, or we could completely ignore it in the case of a very pragmatic trial design. And if you decide to write to the query, this is a spider diagram that you're going to need to use. They want you to show this. And they want you to show where does your study fit into the explanatory pragmatic spectrum. So the most explanatory would be towards the center, and then more pragmatic as we get outside. Here's examples of that, 4 studies. The one to the left is the one that is most pragmatic. The one to the far right upper corner would be the one that is most explanatory across these different dimensions. One example of a famous pragmatic trial is ALLHAT. This was a study looking at treatments for blood pressure and lipids, comparing diuretics to newer, more costly therapies. 8 years NHLBI. A quarter of the people came from UAB. Very nice. 42,000. Very large. Very expensive. Don't expect NIH to pay for too many more of these days. And so we put together a group of stakeholders and asked them, what are the things we need to do to make these studies more effective and to reduce the barriers to doing these? And one was to work with existing networks. Another was to think about how to improve our consent process. And the third thing was, how do we do outcome ascertainment in a more effective way? Can we link people to their administrative data? So we've designed one of these, and we had both a R21 from NIAMS and a U34 planning grant. We worked with the multidisciplinary group across the country. The first most difficult thing was to come up with a catchy acronym. That's always difficult, so we think we did okay on that. The little bone and the edge, so effectiveness of discontinuing bisphosphonates. We thought the question was of some relevance. We work with the Hmo Research Network because you got to find a lot of people for a study that needs 9,000 people. Here's some of the different sites that we engaged with. You can see in one of the large HMOs, over 25,000 people. So this is a very sizable population and a very great way to identify a large cohort. And with all clinical trials, it's recruitment, recruitment, recruitment. How are you going to find the people you need? So you got to have materials and branded stuff that allows you to get the right messages out. And here's some more examples of that. A website. We developed in collaboration with the private sector entity a iPad-informed consent because although we're in an academic center, we're okay with doing consent. We know how to do that. We have coordinators and nurses that do that. Sometimes the investigators even do it. But when you go out into the community, if you really want it to be pragmatic, you've got docs in practice who, that's not their business. That's not what they're about. And they're trying to see 40 people a day, and they don't have time for this. So is there a way to do it in a more effective, efficient way? We developed this application. They say that looks like me, but I don't think so. And so there's these little icons, these avatars rather, that jump around and talk about the study and explain what it is in layman's terms. Another nice thing about this program that shows up on an iPad is that it quizzes people. So you actually get a quiz of how much you know about the study. So that can be very helpful in disentangling this. And then you can e-sign, and the consent form can actually be mailed to people to allow them to receive it at their home. That's been allowed by many of the IRBs. We really view this as part of the idea of a learning healthcare system. This is a construct that's been pioneered now, and the Institute of Medicine is very much behind this. two very well-known national bioethicists, Ruth Faden and Cass, have suggested that we have actually as patients an ethical obligation to participate in clinical research, much like we do in how we deliver healthcare, but it's through this idea of common good that people, when they come in to seek their healthcare, ought to be willing to contribute data. The idea of universal consent, and this is a topic we were discussing yesterday at University of Wisconsin in a site visit. How do we recruit easier in a clinical trial? Can we go directly to patients if we get them when they check in for their clinical care to sign and say it's okay to be contacted? So that there's a lot of ethical and regulatory issues around this. Let me conclude with a section on implementation science, and back to a paradigm that we looked at somewhat similarly earlier. This one developed by some of our former UAB colleagues. I guess Carlos is still here, but Amanda's up at Vanderbilt, and Jerome is now at what we call UAB North in Worcester, Massachusetts. And they put together this model where you can see the different translational science blocks. And you can think about where your research fits into this. And then implementation research is towards the end of this spectrum. And for those who've had Health Services Research 101, you've seen this before. This is the Donovan model, looking at how we transition from a state of lesser to better health, the process of care, the structure, the outcome. These are the things that we're interested in either measuring or impacting as we intervene. What is outcomes research? Its basic tenets are that outcomes, not geography, ethnicity, or other factors, should determine which treatment a patient receives. Variations in practice are indicators of differences. Patient values and preferences should be incorporated. And this pivotal work by Elizabeth McGlynn demonstrated that we weren't nationally doing a very good job in terms of minimal acceptable standards of care. And this is the gap, the underused gap, the traditional focus of quality improvement. Look at a treatment, a beta blocker after a heart attack, and you can see that it was identified years earlier, and then it took up to 10 to 20 years before it actually became widespread. And in fact, the quality indicator for beta blockers after heart attack has been taken away. We're doing such a good job in that area that we don't need to measure it anymore. 90+% of people get a beta blocker after a heart attack. Contrast that with people who have a fracture getting tested or treated, and there it's only 25%. So we still have a lot of room to do in other areas for preventive care. We think about this as part of medical errors. The Institute of Medicine has defined these into three groups: underuse, overuse, and misuse. Traditionally, we focused on underuse and quality improvement. There's an increasing movement towards overuse due to concerns about healthcare costs. Many specialty groups in medicine have established what are called the top 5 list. What are the 5 things in your specialty that have the lowest value? And so cardiology has done this, rheumatology has done this. It's not hard to come up with the list. I mean, the things are out there and very apparent. And those are the things we want to move away from. And then this used to be provocative, but now this is so commonplace that it doesn't surprise anybody. People are being graded. Doctors are being graded. Health systems are being graded. Dr. Ferguson's health system is being graded even, right? Yeah. And so you open the Birmingham News and you see nursing homes in the area being graded. And so this is a type of feedback that might impact quality and maybe should have some implications for how to improve it. So quality is not easy to define. There are different definitions, health services for individuals and populations that increase the likelihood of desired outcomes and are consistent with current professional knowledge. What are the dimensions of quality? Efficacy, equity, efficiency, safety, timeliness, and I think of increasing relevance, patient-centeredness. So implementation research is the rapid uptake of research findings to reduce inappropriate care and improve the health of individuals and populations. And I provoked one or two of you on this as you were describing what you do, because this is at the intersection between quality improvement and health services research. So quality improvement is what you do locally, and it almost always works. You can do Plan, Do, See, Act, you can do rapid cycle. The auto manufacturers have proven to us that this works. You can change process, you can improve outcomes. Does it generalize? Is it something you could then take to St. Vincent's, or you could take to another center somewhere else in the country? Can you describe what you did? That's where we move from quality improvement to evidence implementation. So how do we do this? Well, we can give people printed materials. You can pass out guidelines to doctors. Doesn't work. You can go to continuing education talks if you're a healthcare provider. You get smarter, but you don't change your practice. You can do intensive conferencing, which has had impact on things like smoking cessation. That may help a little bit, but it's very resource intensive. Computerized tools. So those at the VA know about this, or even with EHRs, we're figuring out ways to shut these things off all the time. We don't pay attention to them very much, so there's a bit of a fatigue effect, but this has a lot of promise. Outreach, in a variant of this, local opinion leaders, academic detailing, Steve Sumarai and others have shown that this is very efficacious, but again, it's very costly and very individualized. We've been very interested in audit feedback. I'll give an example. And we thought for many years that multifaceted and multimodal approaches were the strategy, but now we believe it's engagement and context that are probably more important. Why don't interventions work to improve quality? There's a lot of reasons that they don't work. And we have, at UAB alone, a whole series of negative experiments that we've done. And they failed for all sorts of different reasons. It's not generally about people not knowing. That tends to be one of the lesser factors. It often has to do with some of these other variables, particularly the poor alignment with incentives. So busy clinicians, busy healthcare providers need to have their incentives aligned to get it right. Here's an example of audit feedback developed by our colleagues at UAB, Jerome Allison, Katerina Kifa, Norm Weissman, and this was the achievable benchmarks of care, which they use within the Alabama Quality Assurance Foundation. You can see the different quality measures in diabetes. You can see how your practice did in red, the state average in light blue, and the benchmark, the achievable benchmark of care, which was the top 10% of providers with the Bayesian adjustment for practice size. You can see how you compare. And this is not just some arbitrary standard, but it's the top 10% of people in the area. And it turned out that these were very efficacious in improving quality in diabetes. And in fact, CMS said this should be the preferred way that we give feedback, using an achievable benchmark. So we did an experiment. We were interested in the issue of steroid-associated bone disease. If you take prednisone long enough, you will melt your bones away, and you'll get osteoporosis and break bones. And we found that even though there was some improvement over time within a healthcare population, it still wasn't great, particularly among younger women and men. So there was lots of room for improvement. So we designed a group randomized trial. So we identified patients who were on steroids. We figured out who their doctors were, who were doing most of the prescribing. We contacted the doctors. We powered the study to have 150 doctors. We got 75 to 150 to agree to go online. 75 were randomized to an intervention. 75 served as the usual care unrelated CME module control group. We assessed at baseline the rates of testing and treatment for bone health, and then we looked after the intervention at the same parameters. What was our intervention? Well, it was done electronically. It involved adult learning theory with cases. We used this achievable benchmark of care. They could download material. They could go online to get continuing education. It was rolled out over 6 months to combat any decay effects. Here's what we found. So in the intent to treat analysis, the primary analysis, it didn't work. No significant difference between those randomized in the intervention or those who didn't take it. Now, if you looked at the docs who did what we asked, those who went online, those that downloaded their material and interacted, you start to see some trends suggesting that maybe it's about engagement, and really that may be more important. But it led us to think about the different levers for improving quality. You can highlight the provider, you can work at the health system level, or you can work towards interacting directly with the patient. And at least in osteoporosis, we're pretty convinced that working with the doc is not really very good. It's just not a disease that's high enough on their list of interests. There's often not a teachable moment, so a lot of problems. So we moved away from that and focused now more on interacting with the system or with the patient. And at the patient level, we're interested in narrative communication. storytelling, the idea of turning on the TV and seeing an ad that appeals to you. The person looks like you, sounds like you, has an issue similar to you, can relate to this. This is homophily. And the power of narratives to change belief has never been doubted and has always been feared. So brainwashing, if you will, but hopefully for a good purpose. Here's an example of where it worked. This was done over at our county hospital, just down the block, Cooper Green. Jerome Allison, Tom Houston sat a bunch of people down in the waiting room, mostly African-American men. They showed them a grainy home video style DVD, which talked about having strokes and other things. People could relate to the folks talking. And you can see that it had a dramatic effect on improving blood pressure control. And they published this in Annals of Internal Medicine. It's a pretty impressive report using a fairly low-tech approach to trying to impact directly to patient quality of care. So we tried this in osteoporosis. Here's a guy who's telling a story, and this was done in an experiment where when people went online at a pharmacy benefits manufacturing company to refill their steroid, these stories popped up. So it was kind of a cold call. This is a guy we call Alan. So a fairly compelling story, and this guy doesn't look like the typical guy that you'd expect to have osteoporosis, and there's some education then that follows. There's an educator that comes on and talks about what this is all about and why, what you need to do, what are the implications of this. And so we've been doing that. We've also been working with health systems directly to figure out ways to improve access to preventive services, and this was an experiment that actually did work. There's one that finally worked. And so this was a study that it's actually been published now in Medical Care. I need to update the citation. But this is in Kaiser Pacific Northwest, in Kaiser Permanente Northwest and Kaiser Permanente of Georgia. And here, the idea was to just make it very simple to get preventive health care. We randomized women to either receive or not receive the ability to go direct and get a bone density test. They could call a 1-800 number, just like getting a flu shot or getting a mammogram. You don't need the doctor involved. And there was a significant increase in both settings, in two different settings, more so in one than in the other, but the rates were different of access and receipt of this procedure. So a low-tech approach at a system level. So provider level, patient level, health system level. So what can we conclude and what do we know about all this type of work? First of all, you got to define quality. We have an increasing number of ways we can approach this. Implementation research is a team sport. This is team science. We need epidemiologists. We need health behavior people. We need people that are theoretical and knowing how this all fits together, clinicians who understand the clinical questions. And implementing evidence at a community level is not easy. A lot of negative results. Technology offers promises. Theory-based creativity is key, and as my colleague Jerome Ellison says, one size fits none. So we have to think about how to implement and individualize these approaches. And ultimately, we feel very strongly, and this is where implementation science differs from quality improvement, that you got to test the results. You got to test the approaches. Here's the reason. If you look at uncontrolled studies, just open label, looks great. 80% of the time it works. Fantastic. When you actually throw a control in there, it's the opposite. But most of the time it doesn't work. Either gets better temporally or things just don't work when you test it. So I want to conclude then by just mentioning some grant funding opportunities. Many of you talked about where you've been writing. We've talked about the Corey. We haven't talked about AHRQ. Keep AHRQ in mind. It's not a big agency. They have about $350 million a year to spend, but they're moving, somewhat to our regret and dismay, they're moving away from the program projects. Our search grant, for example, is ending, and all the search programs are going away, and they're moving more into R01. So keep an eye on what their RFAs are, because there may be opportunities, even at a fairly early stage, and there's some career development awards that can be written to them as well. And then we heard about these, and I got to add, when Pat was here earlier, she mentioned Department of Defense. That's another great source for supporting this. Resources, of course, include things that you've identified here at UAB. groups that are engaged in this: Academy Health, for Pharmacoepi, the International Society of Pharmacoepi, Medical Decision Making, Society of General Medicine. What else, Sarah? What other things should we have on here that are places, good meetings to go to?
Well, I think you've mentioned the important ones. Society for Behavioral Medicine is particularly good in terms of understanding behavior change. It's just a large part of it.
Yes, that should be on here. Good. And then I think for this group, you're aware of our training opportunities for those that are at the T level. Think about the K level next. We have K-12 and KL2 here at UAB, and we'd be delighted to welcome your applications. And extramural support, of course, for Ks and Ts, and use the CTSA as a way to help facilitate that. So I think we're making steady progress, and I'm going to be embarrassed in advance because I realized when I showed this slide the other day that it didn't include the VA health system and the VA HSR&D program, and Sarah, I promise the next time I show this I'll update it, but I didn't do that yet. But so you can see we're in medical towers with preventive medicine, we're in faculty office towers with the peer group, and rheumatology, we're over at the edge of chaos. We are at the Louder building with Smitabadia, and this right over here should show the VA HSR&D program, which is currently still in the same place, but are you moving anytime soon, or?
No, not soon, but we hope to move at some point, so we're more co-located with similar colleagues.
Wonderful. And so we've got resources here at UAB through the CCTS, the AMC 21, which is the School of Medicine Dean's Initiative, has some money. We're doing targeted recruitment within the Department of Medicine with funds directed to outcomes and effectiveness research. We've got a new Informatics Institute. We're looking for a lead of personalized medicine. Population health disparities has been linked together with outcomes as part of this School of Medicine initiative called the AMC 21. So I think it's really a unique time at UAB to be doing work in this area. There's a lot. Herb Chen now in surgery. We've got a new chair of surgery who's very interested in this. So really, you picked a good time. If you decide to stay in this area and you want to stick around UAB, we'll do everything we can to help facilitate your career. So this is just a partial list of people that have worked with us in some of the pragmatic trial work. Always important to acknowledge your collaborators. And we've ended a little bit early, but I'd be delighted to take any questions, any discussion. Sarah, you may have some things you want to interject and correct any mistakes I made in terms of the sort of associations and overview. So, any comments?
No, I thought this was a wonderful integrated presentation and really nice work presenting what impact you eventually can have through implementation science. And I think the interest now really is comparing in implementation science different implementation